All right, well, let's scooch completely away from the lungs and let's get down into the bowel.
I like
How's
it.
that?
I like
So we're
it.
going to do mesenteric ischemia. The title of the article is very cleanly Mesenteric Ischemia, New England Journal of Medicine, March 2016 by Clare and Beach. This is a nice review article, actually. It's
Yeah.
kind of tight, nice little succinct review article talking about mesenteric ischemia. And it is just basically not enough blood supply to the viscera, particularly your bowel. Small and large bowel. And depending, it really depends, how bad it is depends on, do you have collaterals for one thing? Because if you have collaterals and you clot something off, you're doing okay. If you don't, then you're in trouble. And which vessel's affected? Because some vessels perfuse more of your gut than others. Now, it's not common, but I'll tell you the people who see it are we are. We're the people that see this.
Right.
And the scary thing is, even though it's rare, it just kills people. And actually the data, it's not in this article, but this mortality of 60 to 80% has been that way forever.
Yeah.
Interesting, even with what we try to do acutely diagnosing it, we still lose a lot of people who have this. It's just bad to necrose your bowel. So what we'd like to do is give people the best shot they can. So we'd like to diagnose this quickly and intervene, especially, it's really important as quickly as you can because it can affect their outcome. Now, the most common reason people get bowel ischemia is arterial obstruction. But that can be either acute, something happened right this minute, or chronic. Acute is a surgical emergency. This is the person that we see, and most of those, about half, are embolic. So they have AFib, they throw off a clot, and that's an embolic thing. Or they may have thrombosis of a vessel that's already stenotic. So that now gets a clot in it. That's about 20 to 35%. A rare but not never cause of this is dissection. Now, I've never seen a dissection case that I'm aware of this, but that's another, dissect into one of these arteries and you can still have the trouble. Now, chronic mesenteric ischemia. So this is something, it's still an arterial problem. It's still a flow problem into the gut. Chronic mesenteric ischemia is often due to progressive atherosclerotic disease. So I have bad vessels everywhere, including to my gut, and it's just a progression of that. It's just getting skinnier and skinnier and skinnier, tighter and tighter. The goal on both of these is to get blood supply back. So my goal, whether it's chronic or acute, whether it's embolic, thrombotic, whatever, my goal is to get revascularized as soon as I can. You can still, though, also have poor perfusion of your gut non-occlusively. Now, this is 5 to 15% of the time, and we probably see this more than we realize.
Yeah.
So it's a flow problem. This is, I'm anemic, I'm hypotensive, I'm septic, I'm on pressors, and I get belly pain. It's a low flow state, some sort of reason that they either have bad cardiac output or can't get blood supply to their gut. Hemodialysis is an independent risk factor for this. So this, and actually I'll tell you, dialysis centers are aware of this entity. If somebody gets belly pain while they're getting dialysis, they get shipped off to see us. And the treatment to that is, whatever is making my flow not good, I'm going to improve my flow. I'm either going to perfuse it better by getting blood pressure up or giving blood if that's what I need. I'm going to fix that. Get them off pressor if I can. That's what I'd like to do.
And this is the type that happens in patients in the ICU that are on pressors who
All
have
the time.
they have bowel necrosis from basically this low flow state. So critically ill patients can have this.
Right, and so you can also see it in the ER. So you got somebody you're sticking on pressors because they're septic, but they're awake and still talking to you. Now they have belly pain out of nowhere. It's like, what is that? That may be the problem. Now, perfusing your gut, the pathophysiology of this, you have 3 primary vessels that perfuse those many, 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 many feet of bowel that you have in there. The celiac artery, the superior mesenteric artery, and the inferior mesenteric artery. Now, over time, as you get older and your perfusion's not so great, you'll develop collaterals like you can anywhere. But if you don't have collaterals, and acute obstruction can cause trouble. And the most common vessel involved is the superior mesenteric artery, which is kind of something that might be a question.
Yeah, SMA.
That's a really, SMA is like, that's a really good question thing. And that can cause, it perfuses a whole lot of your gut, so it can cause catastrophic ischemia. Chronic, again, the chronic occlusions give you some time to have collateral. So even then, occluding the big one, you can still have enough collaterals to not be super sick with that. But acute definitely is a problem. Now, interestingly, I didn't know this. Mesenteric ischemia is a problem of women. 70% are women. I didn't know. Did you know that? I didn't know that. I thought that was fascinating.
Yeah.
So when you're seeing someone who might have mesenteric ischemia, you're going to basically focus your H&P, your history and your exam on, is there any evidence of vascular problems anywhere else? Have they had a stroke? Have they have a heart attack? Are there carotid bruits? Do I hear a bruit in the belly? Is there, something I can, are their peripheral pulses terrible?
Yeah.
That's going to tell me they have vascular disease. And then you're also, when you assess them though, also going to figure out morbidities. Have they had a heart attack? Do they have congestive heart failure, where it's going to affect how I evaluate this person and treat
remember,
them?
this is a patient that we're seeing for abdominal pain. So these often aren't the standard questions that we're asking for patients who have abdominal pain. You have to sort of add these to your list if it's that pain out of proportion type of presentation that you're thinking about. Or when these risk factors come out, to think about, did I think about mesenteric ischemia? They're at very high risk for this.
Right. Now, that pain of proportion that
Yeah.
Jan just mentioned, any ischemic pain tends to be out of proportion to your exam, at least initially.
Right.
And that's almost anything. Testicular torsion, ischemic bowel, almost anything, the pain is out of proportion initially. Some
it's not
patients
100%.
don't.
That's right.
Some patients don't. And the ones that don't it's usually not a huge total occlusion quite yet. It's just getting there, or just know that it's not, it is not the be all and end all.
It is not pathognomonic.
No, not at all.
A lot of people, just like most abdominal pain conditions,
exactly.
like API and everything else, like it's not perfect.
No, not at
we
all.
learn these things, but it doesn't always happen.
Yeah, the patients don't read the books.
That's right.
So they don't read they don't read the books. Now, if you do see somebody who has pain of proportion and now they're tender too, that's trouble. That means the bowel is dying. Basically, they have peritoneal irritation now. The older people or altered people are where this conundrum comes up, because they may not be able to tell you their symptoms or communicate clearly what's wrong, or they're just writhing around and can't talk to you, and something's wrong and you just don't know what. And if you have somebody who says, I was fine. So I had a patient who years ago I saw who he was watching Wheel of Fortune, and he said, Vanna turned a T, and I got severe abdominal pain. It's like, there's really not, that's pretty acute.
Yeah,
and that
pretty
pinpoints it
specific.
right spot on. In that kind of person, there's an embolism somewhere that happens. So you're going to look for the embolism. You're going to look for AFib on the EKG. You're going to listen for a murmur. You're going to see if they've had a heart attack where they may have a clot in there. So you're going to actually look for the source of that on your history and your exam. Now, one of the things that is interesting is you not just obstruct your bowel on the blood going in. You can obstruct your bowel on the blood going out. So if I end up with a venous obstruction for some reason, so say I clot my superior mesenteric vein instead, or I have a clot in my inferior vena cava proximal to all this stuff, I can now basically get a congestive ischemia of my bowel. Now, these people tend to be a whole different ballgame. This is the person who's hypercoagulable. This is the person who has chronic liver disease, where they're more likely to clot. Somebody who's had clots before, lupus patients, inflammatory diseases. And they come in, they're more difficult. These are people that end up with kind of vaguer symptoms. I saw a guy who got this, who was riding a century bike ride, never undoubled himself from his bike and didn't hydrate, and came in with this several days later. He had a venous outflow problem because he clotted off his venous drainage of this. So these are harder cases, but again, it causes ischemia, more congestive than actually flow into the gut. This chronic arterial stuff is even different from that. So say I'm somebody who, I've had a heart attack and I've had a stroke, and I have bad perfusion to my legs, and when I eat, I get stomach pain, so I don't want to eat anymore, and my doctor thinks I have cancer because I've been losing weight and I have no appetite, or I just feel sick. What's happening is I have an occluded vessel because it has atheromas in there. It's insufficient blood supply distally. Now I stress it by eating. So I get postprandial pain, abdominal pain. I can have changes in my guts, either diarrhea or constipation. I lose weight.
It's like claudication of the gut.
It's claudication of the gut, and it's intestinal angina.
Yes.
And these people come in often looking like a cancer patient. What they'll do is postprandial pain about an hour to half an hour after eating. They are afraid to eat because it hurts. Our job is to not just say, oh my goodness, here, take some medicine for your, I don't know, maybe gallstones. Know that in a high-risk patient who has vascular disease, think about this, because you can actually save them a lot of agony. When you do see somebody who has mesenteric ischemia, that's on your differential, you're thinking about this, whatever cause, you're going to assess fluid, electrolyte, and acid-base status, okay? And look for signs of infection as well, but you're going to assess that stuff, and your lactic acid is super important to order. That's the dying bowel, you're releasing lactic acid. Now, what's interesting, though, is if you have a really good clinical setting for this, boy, it sounds like mesenteric ischemia. It was abrupt in onset, or it's pain out of proportion, or gosh, it sounds like even if the lactate is normal, you're still going to go right on and do testing of that gut.
Don't talk yourself out of it.
Don't talk yourself out of it. You were right when you walked away from the bedside. Don't let the lab convince you that you weren't. People who have ischemia often bump their white count and left shift it like crazy, so also think about that. And know that there's no specific biomarker that says, hello, this is a case of mesenteric ischemia. So know that you're going to have to trust your gut. You're going to have to trust yourself.
I like it. I like it.
I know. That's for Ken Milne. Thank you, Ken. There you go. You have to trust yourself if you suspect this is what's going on. So if you need to go on to further testing, because I think that's what's happening, what are my options? Well, ultrasound is one, which is interesting, actually.
Yeah,
I wasn't totally aware of this.
Yeah.
But it says that the sensitivity and specificity is 85 to 90%. It's great at proximal vessels, except you're doing something into the gut area. There's bowel gas in there, and the technician may not be so great at this. And honestly, this is probably best in that chronic ischemic case where they're coming back and we know we have it, we know what they were before, maybe. And honestly, this is more outpatient. I'm following you for chronic ischemic stuff. I'm not acutely sick. So Ultrasound, lovely and interesting, skip it over in the ER, because what you're gonna go to is CTA. We were talking about this. This is not just a CT of the abdomen with contrast. This is a true CTA of the gut.
Yes.
So you're saying, I would like you to do a mesenteric ischemia CTA of the abdomen.
Yep.
That's what you want to ask for. Because what they would need to do is do special cuts and timing of the dye.
Yeah.
This gives you a lot of information. Is there anything else going on in there? It tells you where the lesion is, which is often very important to their management. So you really, and if there's any complications, do they have pneumatosis in the gut already? Is there air in the portal vein? Is there free air? It's really good at helping you. So CTA, maybe MRA, but really CTA is and CTA, ask for the right thing. Because they need IV contrast and thin cuts. They need to reconstruct this thing so they can see where all the bits and pieces are, where the issue is happening. And honestly, it is a very accurate study. It's better for arterial than it is for venous. But if you think this might be a venous case, maybe I think this is an outflow problem. I'm a risk person for this. They're having what sounds like ischemic stuff in there. Ask for 2 phase. They'll look at both the arterial and the venous phase, and then you get both pieces of information. Now, can you do an MRA instead? Sure. Doesn't radiate people, but to be honest, it takes longer. It's hard to get people into scan. It just isn't as good. Get a CTA. Do a CTA. It's the cleanest and easiest way to do this. Now, can you look in there and see the ischemic bowel? Well, honestly, most of it's ischemic beyond what a scope is going to see. It's just not terribly helpful, so no. Can you do catheter angiography, which is what we used to do. Before we did CTAs, we used to call in the radiologist to go in there and put a catheter in there. It turns out we don't need it anymore to make the diagnosis because CTA angio is great. However, sometimes this is now a way to treat. So sometimes they'll actually go in there and do things like angioplasties or do certain drug injections in the area, intraarterial vasodilation. So it's not off the table, but now it's more a treatment than it is a diagnostic tool. When you see somebody with mesenteric ischemia, you walk away from the bedside and say, oh my goodness, AFib, abrupt onset pain, Vanna turned to T, and you got belly pain. You're going to need fluid, lots of fluid. You are going to third space into this bowel that's not getting perfused like crazy, and you may need up to 20 liters in 24 hours. So just know, don't hesitate to start to fill the tank. Okay, you're going to use a crystalloid for this, definitely. And if their pressure drops, try dumping fluids into the system rather than using a pressor, because all the pressors just make this thing worse. You're going to monitor their acid-base status very aggressively. You're going to watch their electrolytes very aggressively. And you may need to do invasive hemodynamic monitoring if they get really, really sick. That's, again, ICU, not as stuff in the ER so much. Initially, if it's a clot problem, acute ischemic, right? So it's acute ischemic ischemia and an exacerbation of chronic ischemia, those patients need to have heparin immediately. Yeah. You want broad-spectrum antibiotics right away, which makes sense, right? Yeah. This bowel that's full of bad stuff is now going to get everywhere. So you're going to use antibiotics early. And if they have acute ischemia, don't feed them. Don't strain the system, okay? And they may need a procedure anyway, so don't do it. What do we do? Well, this is kind of cool. They do endovascular repair now for the vast majority of these cases, and they do quite well. So instead of going and opening people up, they may do endovascular repair. You have lots of options. They can do a plasty, they can do a stent, they can lyse them, they can actually take clot out endovascularly. There's lots of options. This is why interventional radiologists have extra houses and extra cars, because this is something they can do. It works for both thrombotic and embolic stuff, so you can use it either way, and you've got to watch them. Okay, this is just, if they don't fly from the endovascular, which they may not, then surgery is the way to go. They may need to do surgery. And open repair is still done actually primarily by some people still, but I tell you, most people do it staged. Try it endovascular if they can, and then go on to the operating room if they need to. What they do when they open the belly, you'll hear these horror stories of what they find when they open the belly, but there's very clear where the dying bowel is, and they can take out the part of bowel that's dead. What's interesting is that they tried their best to not take out too much bowel. So it's not uncommon that those little edges need to get checked later to make sure that they've really gotten everything that's dead in there or dying. So as far as chronic ischemia is concerned, all patients who end up symptomatic, this is sort of like ischemia. Now I have coronary artery disease, and now I'm having chest pain every time I walk. That person needs something done. Same thing. Every time I eat, I get belly pain. They need to have some sort of revascularization, and that's almost always endovascular. 70 to 80%, they do it with some sort of stenting, and they do quite well in that particular group. Venous patients are treated with anticoagulation. Again, they tend to be hypercoagulable, so they're heparins first, and then eventually they put on long-term therapy. So, and it does help people a lot, decreases risk sort of death and recurrence, so it's worth doing this, definitely. And if it's unsuccessful, they can try to get into the vein endovascularly, but generally this is done with anticoagulation. Now, if it's that non-occlusive thing, I'm not perfusing my gut because of a low flow state or marked anemia, you're going to fix it. So again, the mortality rate is, but you're already sick. So these people are usually already sick. Mortality rate's really high. And what you really want to do is get their volume status up if you can, get them off pressors if you can, consider something like vasodilators, which is a possibility, but that's, again, beyond us. We're not going to make that decision. No. Maybe anticoagulate. That's, again, not usually. Our job is to get the tank full and get someone involved who can actually take care of the big picture here.
That's right.
Long-term care, basically, if someone survives this on their way out the door, they say, quit smoking, take care of your blood pressure, take your statin, take your aspirin, blah, blah, blah. All the vascular stuff is all the sort of long-term stuff. People can recur. Right, so I have AFib, it's not adequately treated, I threw a clot once, you can throw it again, or I have known vascular disease, it can happen again. Basically, the patients just need to be informed of what can happen when they go home. So to summarize overall, especially the stuff for us in the ER, it's women more than men for mesenteric ischemia. Arterial obstruction, which is the most common, it's usually acute and it's usually embolic. It may be thrombotic of a stenotic vessel, it may be dissection, but it's usually acute and embolic. It can be chronic, again, that's that intestinal angina person. It may be outflow, which is venous, and it may be non-occlusive, where it's just a perfusion flow state issue. Your exam is going to focus on the vessels, so total body, everywhere, atherosclerosis and cardiovascular stuff. Your labs are going to assess fluid status and acidosis. Again, you're not going to count on them having elevated lactic acid to go continue on to do an imaging study, which CTA angio is the most commonly ordered test. And then your treatment, you're going to tank them up. Large volumes of fluids, watch their hydration acid-base status, heparin for ischemic stuff, arterial and venous, broad spectrum antibiotics, keep them NPO, and then get a consultation. Get them taken care of. That's your goal on these deals.
Great overview.
It's a really good overview. It's actually nicely done.
Yeah.